In this video, we will demonstrate the use of fractional flow reserve pressure monitoring in order to facilitate submaximal angioplasty for intracranial atherosclerotic disease. This is the case of a 53-year-old woman who initially presented with word-finding difficulties as well as left-sided weakness. She had resolution of her symptoms spontaneously, but CT stroke study demonstrated a short stenotic segment in the right M1. This perfusion imaging demonstrates increased time to peak over the entire right hemisphere. For this procedure, we fully heparinize and use a stable access platform through which we'll ultimately do the angioplasty. Diagnostic angiography re-demonstrates the short segment stenosis. Here we see advancement of a microwire in jade fashion up through the internal carotid artery. Ultimately, we'll want to have the wire deployed into a distal M2 segment, but given the severe stenosis, we don't want to cross in a jade fashion. For this, we bring the microcatheter up to the ICA terminus and withdraw the wire, reducing the J and allowing us to try to cross with an unjade wire. Here we see the wire advancing to the region of the ICA terminus and ultimately across the lesion. Patients in care are required to prevent dissection of the vessel in the stenotic segment. Twisting of the wire allows for it to find the lumen and ultimately pass beyond the area of stenosis. Once across the stenotic segment, we rapidly advance the microwire into a safe M2 distal position that will allow for a stable platform for future devices. We then advance the microcatheter across the stenotic lesion, withdraw the microwire, and then advance the pressure wire through the microcatheter. Of note, the pressure wire should be normalized to arterial blood pressure proximal to the area of the stenosis so as to get a ratio of distal to proximal, which will give us an indication of the severity of the reduction of flow. Here we see that proximal to distal ratio is approximately 0.4, which indicates quite a severe degree of stenosis and limitation in blood flow. Once we've made that measurement, we re-advance the microcatheter over the pressure wire and withdraw the pressure wire from the system. This follow-up run demonstrates again that area of stenosis with the microcatheter in place, at which point our microwire is re-advanced into a distal position in the MCA and the microcatheter is withdrawn. We next desire to advance the balloon to the area of the stenotic segment. We can see some motion from the awake patient because this can be somewhat painful. For submaximal angioplasty, we use a strict regimen of slow balloon inflation, inflating approximately 1 atmosphere every minute and resting between. We monitor with fluoro shots at each inflation in order to observe any movement of the balloon due to watermelon seeding or similar movement as it inflates. Once we achieve nominal pressure, we take a single fluoro shot to document that and leave for 2 minutes at that pressure. Deflation proceeds at 1 atmosphere every 15 seconds until we get to 2 atmospheres, at which point we deflate completely. A follow-up run demonstrates some good flow through that region, but we decide to do another round of submaximal angioplasty, again inflating slowly over the course of several minutes. When selecting a balloon for submaximal angioplasty, we desire a balloon that is not so large that it may rupture the plaque and cause subsequent stroke, but that is large enough to increase the flow to approximately 70% of the nominal diameter. Here we see the balloon deflated again after the second round of submaximal angioplasty, and this time the angiogram demonstrates good flow across that stenotic segment. At this point, the balloon is withdrawn, the microcatheter is withdrawn, and a follow-up angiogram demonstrates good flow through that segment without any evidence of extravasation.